Okay, everyone, thank you so much for joining us. Welcome to our Digital Infoday session. In this event, we're going to be discussing the immune system, what it does, and how important it is. We're also going to be covering how you can reduce your risk of infection, how infections are treated, and discussing vaccinations. Just a little bit of housekeeping. The event is being recorded. It will be available to watch on our Facebook page and our website soon after. The structure of this webinar will be a presentation from myself and with our speaker, Dr. Kerry Bygrave, and then we're going to have a Q&A session at the end. If you want to submit any questions during the event, please use the Q&A box, which should be down at the bottom of your screen. Also, if you want to just have a chat and speak with one another, you can also use the chat option. And we're going to be posting useful links in this throughout the event. If you've got any questions and perhaps you'd rather not ask them this evening, or you think after the webinar is finished, oh, I wish I'd asked that one, you can always talk to your haematology team, or you can get in touch with us via the Myeloma info line and ask the nurse service. My name's Kat. I'm the Scientific Knowledge and Communications Officer at Myeloma UK. Some of you might not be that familiar with Myeloma UK, and I'd like to tell you just briefly a little bit about who we are and what we do. So Myeloma UK exists to support all those affected by myeloma and its related conditions, and that includes those with smouldering myeloma, MGUS and AL amyloidosis. We are patient focused and we aim to empower, inform and support patients in absolutely everything that we do. As an organisation, we rely on the generosity and kindness of supporters fundraising and donating. Myeloma UK receives no core government funding, so your support is really vital, and we are truly thankful for all contributions as they allow us to continue doing the work that we do to help patients, their friends and their family. I'd like to give a warm welcome to this evening's expert, Dr. Kerry Bygrave, who's the clinical lead for myeloma at University Hospital Wales. So we're going to hear a little bit from Kerry shortly. But before I hand over to Kerry, I'd like to begin this evening's presentation with a brief overview of the immune system. So as you can see on this slide here, the immune system is made up of loads of different parts. They all have different functions. There's loads of different cells involved, and some of them have really interesting names too, but don't worry, we're not going to quiz you on how to pronounce them. They all have really different functions, but they all link very nicely together. And although they have separate parts, they can be split into two groups that you can see on the next slide. So here you can see on the left-hand side in the blue, the innate immune system. So this is the part of the immune system that acts straight away. It identifies, if it identifies a foreign organism, it goes out, it kills it, it gets rid of it. It's not specific, it's very rapid, and it will go after anything that it recognizes as potentially harmful to you. On the right-hand side of this slide, you can see the adaptive immune system, which is in that reddy-orange colour. This provides a much more targeted defence. It's the part of the immune system that learns. Adaptive immunity is activated by exposure to foreign organisms, and it learns to identify that organism it's been exposed to and remembers them. So this means that our bodies can react a lot faster if it needs to fight the same organism again in the future. So the adaptive immune system is most important for vaccinations. On this slide still, the two cells to really take note of are the B and the T cells. So these are the cells that form memory against infections. A type of B cell that probably most of you will have heard of are plasma cells. So the B cells make proteins called antibodies, and we'll see a really nice diagram of antibodies on the next slide. So as a myeloma patient, you might have heard about antibodies, but maybe in the context of paraproteins. So paraproteins are antibodies that are produced by myeloma plasma cells, but these paraproteins, these antibodies, have no use in the body. They're completely different to the antibodies that are produced in response to an infection. Our bodies actually produce millions, if not trillions, of antibodies to fight loads of different infections. And antibodies are specific to one organism, but one organism or infection can actually have lots of different antibodies to fight the same infection. So that's my quick overview of the immune system. I'm now going to hand over to Kerry, who will begin her presentation on infection and the immune system. Over to you, Kerry.
So thank you, Kat. Thank you to Myeloma UK for inviting me to speak to you this evening. It's nice that we can get together virtually online for an information session like this. I know many of you perhaps in the past would have benefited from coming in person to information days, and I certainly enjoyed doing them in the past with patients and their families, and I hope that there will be a chance for us to do that again. But until that point, we'll do it virtually. So my name's Kerry Bygrave, and as Kat has already said, I work at UHW in Cardiff, which is a large university teaching hospital, and with my great team, I look after the myeloma service there, and we also run a regional MDT across South Wales and have links with the UK Myeloma Research Alliance and UKMF. So it's very kind of you to invite me to speak, and I'm just going to summarise what I'm going to cover this evening. So Kat has already introduced this topic brilliantly, and really there's not much more for me to say, but I will add some detail about how your immune system works. But also the main thing that I want you to think about is how myeloma damages your immune system, because whenever someone's diagnosed with myeloma, or a family member is diagnosed with myeloma, or even if you have MGUS or smoldering myeloma, it's always really useful to think about what that actually means for your body. And with some other cancers, obviously it's much easier. So if you were diagnosed with lung cancer, it's very easy to picture where the tumor is affecting your body. And that may well connect with some symptoms that you might have. You might be coughing, or you're short of breath, or you might cough up with blood. When you're diagnosed with myeloma, as someone who's not medical, I'm sure it's very difficult to understand, well, where is that tumor, and how is it affecting my body, and how and why might it make me ill? And then when we start talking about plasma cells and antibodies and immune systems, unless you've been to medical school, that must be very difficult to understand. So if you remember nothing else from this talk, what I want you to think about is that having myeloma and having a plasma cell disorder is almost like having a cancer within your immune system. And that's why infection is such a huge topic, and it's such a key part of what we do, and also how we try and protect you from the consequences of that, basically. So my 3 take-home messages, which we'll repeat at the end, so you don't have to remember them all now, are that infection is a significant risk to patients with myeloma. And actually, unfortunately, not to paint too bleak a picture, it is the most common cause of death in people with myeloma. And that's huge. And perhaps that's sometimes under-recognized. I hope that we do everything we can to make patients and their families aware. But certainly, perhaps doctors that don't work with myeloma every day aren't necessarily aware of that. And so that's why we admire so much the work that Myeloma UK do to advertise this and publicise this and do everything we can to protect patients. However, although infection is a risk, there are lots of things we can do to minimise that risk of infection. And that's why people like me spend so much time talking to you about antibiotics. And that's why if you've had to start on chemotherapy, you might look at the list of drugs that you've been asked to take and think, well, never mind this chemotherapy drug and this steroid drug and this other chemotherapy drug, why am I taking these antibiotics? And why am I taking this antiviral drug to prevent shingles? Nobody told me that was part of the deal. I was just expecting chemotherapy. And And that's a very realistic question to ask. And I wouldn't be surprised if people are quite bewildered about that. And I'm sure it must be frustrating to have to take many, many tablets, but there are good reasons for this. And so we'll talk about that as we go along. But as Kat said already, this talk is not meant to be frightening, it's meant to be empowering. And if you have any concerns about your infection risk or anything else that we've discussed, you should, of course, talk to your myeloma team. And hopefully that includes doctors like me, but also your nurse specialist team and other members of the group. So, as we said already, unfortunately, one of the problems with myeloma is that the cancer itself damages your immune system. So although there's lots of other knock-on effects of having myeloma that we're not going to cover in this discussion, such as a risk of being anemic, a risk of having kidney failure, and a risk of having bone damage and potentially pain from that or broken bones, unfortunately, myeloma doesn't just hit you in one area, and in almost everybody, it affects your immune system and it weakens your immune system. And that is because the cancer cells are plasma cells. And if you remember the diagram that Kat showed you earlier, plasma cells are a fundamental part of your immune system. So they come under the group of cells that are called B cells, and their normal role is to make these antibodies. And antibodies are like your defenders, basically. They take some time to build up, but their job is to recognize infectious invaders and to fight them off. So having the cancer itself weakens your immune system. And unfortunately, what that means is that infection becomes a greater risk because you just haven't got as good a defense against common infections that potentially wouldn't be such a problem if you didn't have myeloma. So here's a little picture that will hopefully illustrate what I've tried to explain in a much more simple fashion. So on the left side of the screen, as you look at the screen, you'll see a cartoon representation of a normal immune system. So the little blue guys holding daggers are your antibodies. And the green spiky guys are, let's say, bacteria or a virus or something else, just to keep this simple. And in healthy people that don't have myeloma and don't have any problem with their immune system, when the infectious agents invade, antibodies can be released and they can fight them off. Now, in a myeloma immune system, as Kat said, the same cells, the plasma cells that should be making these strong blue antibody chaps with the daggers, they are plasma cells that are making paraproteins. And paraproteins are effectively useless. They are immunoglobulin molecules, they're antibodies, but they don't have any function. It's as if their daggers have been taken away. So those purple blobs represent the myeloma plasma cells, the cancer plasma cells. And what you can see is that when you have lots of those swimming around rather than lots of normal plasma cells, your ability to fight an infection in that way is much, much weaker. And that is the problem. And one thing that's worth remembering is that this is more of a problem perhaps at the beginning when you're newly diagnosed. And it's something that can improve once you've had treatment and you've achieved a remission and your bone marrow is more healthy and perhaps contains fewer myeloma plasma cells and more normal plasma cells. So one of the other complex terms you might hear us mention in clinic is immune paresis, and that's doctor speak for low antibodies. And having low normal antibodies is a feature of having myeloma, but it's also something quite reassuring that we can look at to see perhaps after you've had your chemo, after you've had your transplant, your normal antibody levels can actually rise, and they can rise back into the normal range. And so that's one of the things that we monitor when we see you in clinic after you've had chemo or after you've had a transplant. And it can be another reassuring sign of being in remission and having had a good response to treatment. So there is a worst case scenario, obviously, which is when your immune system is very weak. But there are ways we can improve that, either by getting a good response to treatment and getting you in remission, or some other techniques that I'll talk about over the next couple of slides. So, okay, we're talking about infection. What does infection mean? Where are these infections going to affect me? Are they all the same? Will I always get the same type of infection? Will I get the same type of infection as the person sitting next to me in clinic? These might be questions that are running through your head. And the simple answer is that, unfortunately, myeloma can weaken your immune system such that any type of infection can be more common. It doesn't mean everybody gets them, but it can be quite varied and quite widespread. And actually, if we go back to diagnosis, recurrent infections is one of the common symptoms of having myeloma. So some people present, let's say they had 6 months over a winter, and they had 3 prolonged courses of antibiotics for a chest infection that they just couldn't shift. That can be part of the way that myeloma presents. The problem with that is it's extremely non-specific, and there are many people who will get recurrent chest infections in the winter. They might have underlying problems like asthma, or they might be a smoker or whatever, but the line between myeloma recurrent infections and common or garden recurrent infections can sometimes be quite blurred, and that's one of the reasons why it can be quite difficult to pick up myeloma. But nevertheless, infections can happen anywhere. Chest infections are a common sight, but I've seen people present with infections around the skin, perhaps in the ears, cellulitis, which is our term for kind of reddening and inflammation of the skin. That can be a common one. Urine infections, UTIs that don't go away, perhaps infections of the eyes, colds, that kind of thing. It's almost anywhere, but it all comes back to this problem of having a weakened immune system. So that's what we're dealing with. That's what we're up against when we have someone with myeloma, someone on chemotherapy, someone that you live with that is affected by all of this. But as I said, there are lots of ways that your doctor and your nursing team can help protect you. So one of the most obvious ones is antibiotic tablets. And the term that we use is prophylaxis. And what that means is preventative, basically. So these are not antibiotics that we're giving you to treat an existing infection. They're antibiotics that we give you to minimize the chance of you developing an infection whilst you're on chemo. And the key word there is minimize. So unfortunately, there is no antibiotic, and there is no vaccine, and there is no intervention that will take anybody's infection risk down to 0. That just doesn't exist. It doesn't exist in any situation, myeloma or no myeloma. But studies have shown that taking antibiotics while you're on chemotherapy can reduce the risk of you picking up an infection, and that's why we recommend them. And as I said, that's why you'll see antibiotic tablets in with your bag of drugs that you might get when you start your chemo. It's quite uncommon for people with myeloma to be admitted to hospital while they're on chemotherapy. I wouldn't say it never happens, but one of the positive things about having myeloma is that most of the chemotherapy we give is given as an outpatient. And if you take away transplant and that kind of things, the majority of people are able to spend most of their time, even if they're on chemo, at home. But every now and then, we get patients who develop an infection while they're on chemo. So you might get a high fever, or you might have a nasty cough or anything like that. And your medical team will give you contact numbers so that it doesn't matter when this happens. If you've got a high temperature and it's 5 o'clock on a Sunday afternoon, you would be able to call someone and they would be able to get you some medical advice from your local hospital and, if necessary, admit you. So sometimes we do need to give antibiotics through a drip to prevent an infection that might have developed while you're on chemo. Antiviral tablets we've talked about already. The most common one we give is a drug called acyclovir, which are the little pink tablets, and they minimize the chance of you getting a reactivation of shingles. And acyclovir is commonly given with any type of drug that's in the family called proteasome inhibitors, or PIs. And PIs include things like Velcade or bortezomib, carfilzomib, and ixazomib, because that particular group of drugs, for some reason, increases your chance of having a shingles reactivation. So that's why we recommend you take acyclovir. So that's some things that we can do that are preventative. But of course, another big topic, and one that perhaps many of you will want to talk about this evening, are vaccinations. And the thing to remember here is that vaccinations are safe, and that we recommend people to have them, even if they have myeloma, even if they have MGUS or amyloid or smoldering, because the benefits of having a vaccine far outweigh the risks. There are some caveats that we may get into around the discussion, whereby potentially your chances of responding normally to a vaccine are lower if you have myeloma. And hopefully by now you'll get the idea that it's because your immune system is weaker. So to a certain degree, having a vaccine relies on having an immune system that can respond to a vaccine. But nevertheless, that is very, very variable, and it's quite difficult to predict who will respond to a vaccine and who won't. So the recommendation is, because they are otherwise safe, there's no increased risk from a vaccine just because you have myeloma. We recommend people to have them. The only one is the live shingles vaccine, which you shouldn't have, but there is now a non-live shingles vaccine alternative that you would be able to have. And then finally, point 5 on this slide is IVIG, which stands for intravenous immunoglobulin, which is basically donor antibodies. And the ways these are collected is a bit like when you donate blood. If anybody in the past has ever been a blood donor, there will be antibodies in what's called the serum, which is part of the blood that's taken off. And in the laboratory, we're able to siphon off antibodies, basically, and they pool them from several donors, and then they can be given to people with conditions like myeloma as an infusion to replace some of the normal antibodies that they're not making. So it's like you get some of these blue guys with daggers back again, in place of the ones that you're not able to make because you have myeloma. Sorry, just...
Okay, Kerry, thank you. Oh, are you okay there?
Yes, good.
Slight technical hiccup on our end, but that's our bad. Sorry about that. Kerry, that was fantastic. Thank you so much. I really loved the analogy of the blue little guys with the daggers. That was like really informative and so reassuring. Hopefully everyone felt that at home too. So we've now reached the Q&A section of today's webinar. We're pretty much running on schedule, but we have a lot of questions. So we're going to try and get through as many as possible, but also please do keep adding them in. So there's still space to pop them in the Q&A box. But I will kick us off. We've got quite a few COVID questions, understandably, still on people's minds. So the first one's from June. June says, being in complete remission with no medical conditions and free from all medication, am I still regarded as at the highest risk from COVID-19?
Okay. Anything I'm going to say about COVID will come back to the fact that there is a personal element. And by definition, risk is a personal phenomenon, because your personal risk has to be linked to what you're prepared to accept. So I'm not going to be able to tell anybody that they're safe to go out in the world and there's no risk to them from COVID, because I can't say that for myself. I can't say that for my parents. I can't say that for anybody. What I could say is that somebody who has a diagnosis of myeloma but has been treated and responded well, as in remission, is more likely to have a robust immune system that can cope well with COVID, compared to when you were newly diagnosed, more immune suppressed for all the reasons that we've just described. So I'm afraid there's not going to be any golden tickets in this talk. There's not going to be any off you go, we don't have anything to worry about, because frankly, I don't think that applies globally. We don't really know where COVID's going to end up yet. But definitely things are in a much better position once you've been through treatment, and hopefully by now the slides will have made it clearer that you've had a chance to respond and regain some of that normal immunity that myeloma took away from you. Plus, hopefully you're also up to date with vaccines and boosters and that kind of thing.
Yeah, that's really good. And I was going to add on to that, even if you're in remission from myeloma, you can still access the COVID-19 vaccines. So currently everyone with myeloma should be on their 5th dose. So the spring booster. So the sooner you get that done, the better. And then you'll have the autumn booster later this year too. Got a few more on COVID. So a couple that kind of sit together. Ian has asked, I'm concerned if I go ahead with my proposed stem cell transplant, how this might affect me, especially in light of the COVID-19 risks. And a really similar question from an anonymous attendee, tongue twister there. If my immune system is not as depleted as thought, having had a stem cell transplant in September 2020, will having the extra COVID booster shots risk overdosing me?
Okay, so transplantation is a big topic. It's one of the things that very early on in the pandemic, many of us around the country thought was less safe than it used to be, let's say. And a lot of autografts were deferred or put on hold from March 2020 onwards in almost every centre in the UK. Not every, some transplanted the whole way through. But certainly locally in Cardiff, we massively scaled back our autograph programme during the height of COVID for reasons that are fairly easy to understand. Transplant is an immune suppressive procedure. The idea of the high dose melphalan is that it wipes out your normal bone marrow, and hopefully in the process wipes out as much residual myeloma as possible. So mopping up any of those nasty plasma cells that are hiding in some corner of your bone marrow that the Velcade index hasn't got to. And if we did that and you didn't have your own stem cells to have back, your bone marrow would be empty. But obviously we give you the stem cells back and your bone marrow recovers. But that recovery process post-transplant is quite difficult to predict. And so for a long time, if people did have a transplant, they had to shield, and the amount of time they shielded for was extended. And we don't yet know, coming into the autumn, what the advice around shielding post-auto is going to be. And a lot of that depends on variants and overall cases in the population and that kind of thing. So it's quite difficult to predict, sitting here in June, how that will look in the autumn. So to the person that is yet to go through an auto, I still don't think you can take COVID out of the equation, but certainly our local transplant unit and my local practice is that we're now referring people normally as we did pre-pandemic. To the person that had an autograft in 2020, it sounds like you got through in the year where many people weren't having transplants. And so now in this post-transplant period, with the benefits of vaccination and boosters, I would imagine you'd be in good shape. As I said, there's no such thing as zero risk in any of this, but in terms of, is there a risk from having had too many boosters? I don't think that's any real concern, to be honest with you. I think, to have a good repertoire of antibodies to fight COVID with, having boosters can only be a good thing, and I don't see that being harmful.
Yeah, and I would, I know that's our stance as Myeloma UK, so that's really good to hear. Thank you, Kerry, for clarifying that for us. Another COVID-related question comes from a question that we've had sent in by Steve. Steve's undergoing lenalidomide maintenance treatment and has reacted adversely to different COVID vaccinations. Is this a common side effect for myeloma patients?
I think the question is more, is there connection between the reaction and the lenalidomide? That's not something that I've observed with any great frequency. I have to say, my own story is that I was in a COVID vaccine trial in November 2020, and I actually volunteered and found out later that I got the Janssen one-shot vaccine. And for 24 hours after I had that vaccine, I've never felt more unwell in my life until November 2021 when I got COVID. And then I've never felt more unwell in my life for the next 10 days. So anybody can have a reaction to a vaccine. I had a reaction to a vaccine. My 12-year-old son had a bit of a sore arm. I'm not aware of any evidence of any big pool of data to say that being on lenalidomide maintenance has any effect on increasing your risk of having a vaccine reaction. But I think that anybody who consents to a vaccine should know that there's a risk of side effects, just like there is with everything. But the benefits of the vaccine so far outweigh the risks, both for you as an individual and for us as a population. That's why they're licensed and that's why they're recommended.
That's great. Thanks, Kerry. Yeah. I applaud that second statement. So we've got, you've mentioned shingles quite a few times in your talk, and we've got a question from Fanula. Why are myeloma patients at risk of developing shingles?
So it's actually more to do with the proteasome inhibitor group of drugs. And the easiest way to connect this is that any of you that have ever had a PI, so Velcade, bortezomib, as it's otherwise known, ixazomib, I'm sure you would say that you're aware of, or maybe you've experienced peripheral neuropathy, which is this, at its very mildest form, is tingling and numbness in the fingers and toes that can feel a bit like pins and needles. And at its very worst form, it can be painful and can lead to either dose reductions or dose interruptions, etc. And basically what that's telling you is that the drug affects the nerves, and that's why you get those side effects. Now, the funny thing about the shingles virus, which is called varicella zoster, which is the thing that causes chickenpox, is that it also lives in nerves. So if any of you have ever seen anyone with shingles, the characteristic rash is a stripe, and the stripe can be anywhere on the body, and those stripes coincide with where nerve endings lie in the skin, basically. So it's because that group of drugs are affecting the nerves. They can also mean that the virus which lives in the nerves can reactivate, basically. It's that connection via the nervous system. And so acyclovir is like an antibiotic against the shingles virus. So it's an antiviral drug, technically, but by taking it every day when you're on Velcade or you're on ixazomib, it minimizes the risk of you getting this reactivation of the shingles virus. Hopefully that makes sense.
Yeah, no, it does. That's really interesting. And hopefully that cleared things up for Nuala. Got a couple more questions on stem cell transplants. So Bree has asked, what vaccination should you be having on after a stem cell transplant?
So I'm going to paraphrase our transplant consultant who says you would have your baby jabs. And basically that is what you have. So if any of you have children or grandchildren that have had their vaccinations from 3, 4, and 5 months old, that is the schedule that you follow, basically, because everything that you had when you were 3, 4, and 5 months old is likely to have been weakened by the transplant process. So you have to have your baby jabs again, and then you have to have the usual ones: meningococcal, Hib, MMR, etc., all of that. And there's a schedule that what happens in Cardiff is that transplant team liaise with your GP, and they keep a record of when you had your transplant and when you would be due to start your revaccination process, and they ask the GPs to organise it, but it's a very formulaic schedule, I guess. And in Cardiff, actually, we check antibody response to vaccination. Some, I don't know that all centres do that, but they will also measure when you come for your post-transplant visits at 6 months and 12 months. One of the things they'll be doing is measuring your response to those vaccines. And if, say, you had a suboptimal response to one of them, like pneumococcus, they might give you a booster.
Yeah, so it's a kind of regular process that your GP will be able to help you with.
Yeah, they don't just say, oh, there's no element of doubt. It's not, they don't assume that because you had meningitis vaccine in the last 2 years, you don't need that one. They just revaccinate you against everything.
Wonderful. Cool. Thank you, Kerry. And continuing with stem cell transplants, I'm going to paraphrase Gabriel a little bit. So Gabriel wants a better understanding of how their own immunity develops after successful autologous stem cell transplant. So how does the immune system start to rebuild itself, essentially?
So the stem cells that you're given back basically form the basis of your new immune system. So they're very early cells. They're what we call CD34 positive stem cells, but they have the ability to develop into everything. So if you remember that nice diagram that looked a bit like a tree on its side that Kat showed at the beginning, at the very far left of that diagram, you would have seen something called a pluripotent stem cell, which is a very long word for saying a cell that can turn into anything. So when you get them back, that's what happens over weeks and months. Your immune system repopulates with all the cells that you had to one degree or another prior to the transplant. And obviously some bits come back sooner and some bits come back later, and some bits come back more completely in some people and others in others. But that is the idea, that we give you back this miracle cell that basically, under the influence of things called growth factors, can turn into anything that you need.
That's really great. Really very informative. Thank you. We've got a selection now on I would say lifestyle is what I'm going to call that one. So first of all, we've got a question coming in from Eddie. How can I improve my immunity through dieting and exercise?
Okay. Exercise has benefits across the board. So it's something that I recommend to all my patients at a level that suits you. I'm not going to say that rowing will boost your immune system, whereas walking won't, because it is very personal, and just the effect of being physically active, of moving your body, of strengthening your bones and joints, of strengthening your respiratory system so that you're not coughing and spluttering all winter long, for example, minimizes the risk of you getting chest infections. So does not smoking. That's a huge one. To be honest, we don't really come across many smokers or family of smokers in clinic, but if there are any, that is a huge lifestyle factor that you can take. But yes, exercise is beneficial just from, I guess, making the body more fit and healthy and able to fight off infections. Plus, there is evidence of it having anti-inflammatory properties, and perhaps having other ways of strengthening the immune system that we're not so aware of. In terms of diet, it's not really my area of expertise, I have to say. I mean, I recommend eating healthily, eating a wide variety diet, not having too much of anything. But I'm not able to suggest any amazing superfoods for people with myeloma, I guess. But I think we all know enough about the things that we should avoid, and the things that we should try and get plenty of.
Yeah, absolutely. I think healthy living is just the way forward for everyone, myeloma or no myeloma. But we do have the info pack, Living Well with Myeloma, that you can find on our website. I'm sure one of my colleagues can pop a link in the chat, and that should help with different hints and tips for that too. We've got another really good question from Irene. What are the best ways to prevent infection in everyday life?
Okay, so we talked about smoking, and I'm going to say that one again. Clean air is key, and also one of the big ones that we learned from COVID. So ventilation, getting lots of fresh air into you by going outside, keeping windows open, keeping the house well ventilated, not letting it get too damp, trying not to allow things like mold and mildew to build up in your bathroom. Those kind of things can make a difference. So that's one that we've sort of looked at over the last 2 years, and I think we should carry forward. There will be occasions still where wearing masks are beneficial. I know most of the mask regulations have been taken away. But again, depending on what happens with COVID during the autumn and winter, even if the government is not telling you to wear a mask, it might be sensible to wear a mask in certain situations that are indoors and in enclosed spaces, and that kind of thing. And then the one that I always say is that you never have to wrap yourself in cotton wool. You should, and outside of the beginning of the pandemic, which was obviously absolutely unprecedented, I'm really worried about people that isolate themselves and don't see anyone. But you should avoid people that are obviously unwell. So anyone coughing, sneezing, spluttering, febrile, just ask them if you can either wave over the garden fence or perhaps rearrange that cup of tea for a week or so when they're feeling better, because it just minimizes the risk. It doesn't take the risk down to zero, but obviously hanging out with people that are obviously unwell will increase your risk of getting an infection.
Yeah, it goes all the way back to what you were saying right at the start, Kerry, of the personal risk and personal choice, how comfortable people feel putting themselves into different situations.
Yeah, and that's not something that anyone can tell anyone else. We can all discuss it as a topic, and I think it's really important to discuss it. But at the end of the day, we all have our comfort levels around this kind of thing. But there are some things that we can obviously avoid.
Absolutely. Margaret would like to know, how do you know if your immune system is impaired? And are there any simple steps that you can take to help keep it stable?
Yeah, so we touched on this earlier when I talked about immune paresis. So that is one of the lab blood test features that often goes hand in hand with having myeloma. And we sometimes see it in MGUS and smoldering as well. So you could ask your doctor, what do my antibody levels look like? Depending on where you are in the journey, they may or may not want to intervene, but at least that's some information for you to be aware of. Some centres have got quite far along the line of measuring responses to vaccines. I touched on this in the kind of post-transplant setting, but certain centres did it routinely for their patients after the initial COVID vaccines. Cardiff actually wasn't a centre that ever really did that. The place where we've got more into it recently is when we've been able to give either monoclonal antibody therapy or the new antivirals for people who develop COVID. we had, before we gave them, measured their antibody response, because it was interesting to see how well the group of patients had responded. And the main thing that I could say from that data is that there was a huge variation. There was people who got COVID who had a seemingly normal antibody response, and there were people who got COVID who actually had a low antibody response. So again, I'm afraid there is just no good data on that. Just because the numbers tell you one thing, it doesn't necessarily correlate with what happens in a clinical setting, which is why all of this advice is so personal, I guess.
Yeah, and why it's so important that people carry on getting their vaccines, and
Yes.
that they have access to treatment if they did get a positive COVID test and symptoms.
Absolutely. And the thing to remember is that if we stick on vaccine responses, the test that you do to measure response, one single test can't ever cover all the ways that people respond to vaccines. So earlier on, we talked about T cells and B cells, and there are deep, dark parts of our immune system which are very helpful that aren't necessarily captured in your antibody response number. And obviously that happens because there's some people who have a big fat antibody response number who still get COVID. And it's because, that wasn't the crucial bit of their immune system that was needed to stop them getting COVID. That is a very simplistic but true way of describing it. So the test is only going to be as good as the information that it's describing, and none of this, unfortunately, gives you the full picture. That's why myeloma is so fascinating. That's why immunology is so fascinating, because it is so complex, I guess.
That's really interesting, and that's something that I could natter away with you about for ages. Separately, Martin asks a question: how can you avoid pneumonia, and can you get an injection to protect yourself from pneumonia?
Yeah. So quick explanation here. Pneumonia as a term means infection in the lung. And by that, I mean deep down into the tissues of the lung. And that's different to, say, laryngitis or tracheitis or a sore throat, which is affecting your respiratory system higher up. So if you have pneumonia, in doctor terms, that means you have an infection in your lung tissue. Now, where it gets really complicated is one of the most common bugs that causes pneumonia is called Streptococcus pneumoniae, or strep pneumoniae. And there is a vaccine against strep pneumoniae called Pneumovax. And that is one of the vaccines that you'll be recommended to have regularly. But unfortunately, the Pneumovax will only protect you against that one bug, which is one of many, many things that can cause pneumonia. So there's lots of other bacteria that can cause pneumonia. Viruses can cause pneumonia. Fungus can cause pneumonia. So having a pneumococcal vaccine is very important, but you could still get pneumonia, i.e. a severe chest infection from another bug. And that's why it's only one of several things that we recommend people to do.
That's great. And talking of bacteria, we've received a live question. Someone's actually asked about taking antibiotics. They say if they continue to take antibiotics, will they eventually become resistant to the benefits of the antibiotics?
Yeah, and that's a really good question, and it's a huge topic. Antibiotic resistance is a huge topic. And what you'll find is that over the years, the types of antibiotics that we use for prophylaxis has changed. And that is partly to do with antibiotic resistance. So simple penicillin, for example, a good percentage of the most common bacteria are resistant to penicillin. So that's why you won't be given something like amoxicillin routinely while you're on chemo. You might be given another drug like ciprofloxacin or levofloxacin, is quite a common one, or cotrimoxazole, which is quite broad. Those antibiotics are effective against quite a big range of different bacteria. And currently in the UK, levels of resistance to those antibiotics are low enough to make them worthwhile. But other antibiotics that potentially were used in the past that potentially are more common because of their higher resistance levels aren't used routinely. So antibiotic resistance is an issue, but again, all of this has been looked at in the context of, should we give people preventative antibiotics? Should we give prophylactic antibiotics? And again, we look at it and we look at the evidence and we say, well, okay, none of this is going to bring the risk down to zero, but the evidence tells us that taking an antibiotic like that will reduce your risk of getting an infection enough, and that outweighs the risk of you getting an infection that's resistant to the antibiotic. It doesn't take that risk to zero. It doesn't mean it's never going to happen, but it does reduce the risk.
Absolutely. We've got time for one last question. So this last question comes from James, who says, I've had myeloma for 14 years. Assuming that one has had all recommended immunizations, am I safe to travel abroad?
I would hope so. and I don't know what the right word is, but I'm glad that I know many patients like you that have had myeloma for that long. And obviously it's a testament to you and your team that you've kept well and kept going, and you're in a position to travel. And so everything that we've talked about this evening actually is about supporting you and supporting your immune system. I've also said already, there's not any golden tickets. There's no golden tickets with COVID. I can't guarantee that if you go abroad, you won't get ill, but I can't guarantee that if I go abroad, I won't get ill either. So these kind of topics are about minimizing the risk as much as possible, but they will never take the risk down to zero. And then it comes back to what you personally are prepared to accept. And I think the very fact that you've had myeloma for this long, you've had lots of treatment, and you're still thinking about going abroad is brilliant. And I hope that between you and your team and your GP, we can be sure that we've done everything we can to minimize the risk of you getting an infection and becoming unwell while you're away. I hope that's not sitting on the fence too much.
Oh, I think that makes perfect sense. I think if I were in your shoes, I would have answered exactly the same, of check in with your hematology team, and if you feel comfortable and they feel comfortable, then I hope you have a nice time.
Exactly. Send us a postcard.
Yeah, exactly. So thank you so much, Kerry, for answering all those questions. That's all the time that we have today. But as a reminder, I just wanted to kind of tell everyone at home about all the services that we've got available. So on the screen at the moment, you've got a couple of our info sheets. I know that the team behind the scenes will have been working away and popping them into the chat. So we've got the info sheets and info packs mentioned, but we also have a range of publications that you can download from our website. Or you can also order a selection of hard copies to read at home at your leisure. We've obviously also got the myeloma info line and Ask the Nurse email service. So our information specialists are available weekdays, Monday to Friday, 9 till 5, and they'll be more than happy to take your calls. All our digital info day sessions are up on our website and on our YouTube channel that you can watch on demand. We've also got a discussion forum on the website where you can join conversations with other patients or family members and friends, and kind of share experiences. And talking of shared experiences, last but definitely not least, we've got a range of support groups. These are all over the UK, and you can find details of all of these on our website too. So I'm just going to pass back to Kerry. So Kerry, could you tell us again, remind us of your take-home messages from this evening?
Yes, so thanks, Kat, and thanks for asking me to take part. So my messages were that infection is a significant risk to patients with myeloma, but there is lots we can do to help you, and lots we can do to minimize that risk, and that definitely includes antibiotics, antiviral treatment, and vaccinations. But if you have any concerns, you should talk to your myeloma team. And other than that, thank you all very much for listening.
So thank you so much, Kerry. We've come to the end of our webinar today. It leaves me now to say thank you for speaking and answering so many questions, Kerry, and thank you to everyone who has joined us for this event. We hope that you found it helpful and informative. If we didn't manage to answer your question, or if this brings up new questions to you and you think of them later, please get in touch with us. Our info line and Ask the Nurse email services are up on the screen now. You could also rewatch this webinar immediately on Facebook if you need to capture another piece of information, but it will also be available on our website very soon. Thank you so much to our supporters. Myeloma UK is only able to provide free digital events like this one for patients and their families because of you guys. If you'd like to support the work of Myeloma UK, please visit myeloma.org.uk/donate. The link's also on the screen. And keep an eye out on our website and our social media channels for announcements of the upcoming Digital Infoday sessions. And I'd like to thank you all so much once more, and I hope you enjoy the rest of your evening. Thanks, everyone.